the last 40 to 50 years, children with Carter's condition didn't survive. They were sent home basically for end-of-life care. On our 5-year wedding anniversary, we went to find out if we were having a baby boy or girl. We'd actually struggled with fertility issues before that, and so we were very excited, just thrilled to death. And when we went to have the ultrasound, everything was going good, and once the ultrasound tech got to his abdomen, they realized that something was not right. They weren't sure exactly what it was, but they knew something was not right. Ended up being the diagnosis of cloacal exstrophy. Finding out that the baby you thought was going to be so healthy was not going to be born healthy is just heartbreaking.
Cloacal exstrophy is probably one of the most severe birth defects still compatible with human life. It happens around the 7th week of the mother's pregnancy when the fetus is the size of an American quarter, so very early on. And in this birth defect, the abdominal wall does not fuse in the midline, nor do the pelvic bones fuse in the midline. So therefore, the intestines are on the outside of the body. The bladder is divided into 2 halves, half the bladder on one side, half the other, with a large piece of intestine between that. In addition, 70% of them have some degree of a major spinal abnormality. So it truly is an all-encompassing birth defect.
It's almost like a punch to the stomach that knocks the wind out of you. I mean, it's, it's something that you're going to recover from, but at the time, it's pretty excruciating.
We were not even sure of what Carter's life expectancy was going to be, the quality of life he was going to have. And so knowing as a parent that your child that you've wanted and prayed for and wanted so much is going to be born with this, and not even know if they're going to be able to survive, and there's nothing you can do about it, is one of the most helpless feelings you could ever feel. After getting the cloacal exstrophy diagnosis, we waited a week and then met with surgeons at the hospital we were currently at the time, and found out that one of the surgeons had actually trained here at Johns Hopkins and had worked alongside Dr. Gerhardt in surgery and had experience with this, and so he immediately sent us here to Johns Hopkins.
Here we are waiting to meet this prestigious doctor who, every time we type in anything about cloacal exstrophy on the internet, his name pops up. And so I'm sitting alone in the room, and in walks the doctor, and he starts asking me if I know this person or that person. And it comes to find out our families are from the same small town in Kentucky. And then so he's talking to me like my hunting and fishing buddies. And immediately it was like, okay, we're going to be all right. This is going to be fine. It gave us a piece that we, if a doctor had come in and started using all these big words and terms, I don't know that we would have felt any better leaving, other than knowing that they were capable of doing the surgery. But we knew that after talking with Dr. Gerhardt that not only was Carter going to get treated, but he was going to get cared for.
What they do with this procedure is they actually break their pelvic bone in 4 places and kind of turn it inwards and reset it and put them in traction. That's why they have to be flat on their back for 6 weeks, have to let their pelvic bone heal. They also put their bladder back on the inside of their body.
It is a team approach. As we said, it is a multidisciplinary birth defect. It requires oftentimes pediatric neurosurgeons, pediatric general surgeons, always requires a pediatric orthopedic surgeon, a pediatric urologist. We're very blessed here to have fabulous pediatric anesthesia who can keep these children asleep for 10 to 12 hours and wake them up safely, and who can actually relieve their pain very nicely for the 4 to 6 weeks they're in the hospital.
With a surgery like what Carter just had, pain is just a huge issue. It's one of the most painful procedures they do even here at Johns Hopkins, and so having a pain team that followed him daily, listened to our concerns, looked at him, looked at all of his vital signs, talked with his nurses, and really managed and stayed on top of his pain and sedation just made a huge, huge difference.
The nursing care we received was top-notch too. You hear about all these wonderful doctors at Hopkins, but I've got to give a lot of the credit to the nurses, because that's who's with you 24/7, and they were exceptional. What sets Johns Hopkins Children's Center apart from other places is their knowledge of very rare disorders, very rare birth defects, and the research that they can do to get better at things that no one else can do. And when you come here, you're not that rare case. You're one of their patients, one of their children, one of their families. And that makes it a lot easier to come here and get the care you need, because you're not looked at as like, wow, we've never seen this before.
Now Carter is happy, healthy, he's running around playing. He's a thriving 2-year-old. And so the progress that they've already made is spectacular, so I can only imagine the progress they're going to continue to make.
We take care of these children actually from birth into adult life, and some interesting research projects are ongoing. We've just received in the last year permission from the NIH to go forward with learning to grow bladder sphincter cells in the laboratory from children's own muscle, not from stem cells, but from children's own muscle. We're just on the cutting edge of new discoveries in this field, and because of the volume of patients we see, recruiting new patients for the study is really going to be easy. Carter actually became the 100th coloacal extrophy patient ever treated at Johns Hopkins, and even more uniquely, in the 100th year anniversary of our children's hospital. So he's unique really for 2 reasons.
We're thrilled. We're thrilled that they have hit this number, not only for Carter, but all of the other children that are going through this and are going to go through this, and just all of the progress they're going to make for these children.
He's going to be a normal little boy in most respects. He's going to be able to participate in contact sports. He's going to be able to continue with his education, and he's going to have, other than a few minor little bumps in the road, his quality of life is going to be the same of any other little boy his age.